Hello everyone, I'm Dr. Divya, maxillofacial surgeon from Hyderabad. So today I'm here to discuss about trismus, a condition which is considered to be a common complication of dental treatment. There are several factors which predispose an individual to develop trismus, ranging from motor disturbance of trigeminal nerve to potentially life-threatening conditions like tetanus. Now let's get into the presentation and see what exactly is this trismus, what factors cause this, and how do we manage this condition. Trismus is a condition that restricts the normal mandibular movement and function as a result of masticatory muscle spasm. The word trismus is derived from the Greek word trismos, meaning gnashing, and is defined as a prolonged tetanic spasm of the jaw muscles by which the normal opening of the mouth is restricted. More recently, the term trismus have been used to describe any restriction to mouth opening, including restrictions caused by trauma, surgery, or radiation. The maximal interincisal opening of at least 35 mm is used as cutoff point to determine trismus, and less than 5 mm of maximal interincisal opening indicates complete ankylosis. So roughly put, the mouth opening should permit a minimum of 3 fingers when introduced sideways. Now, what is the normal mouth opening? The normal range of mouth opening varies from patient to patient within a range of 40 to 60 millimeters, and the lateral opening is 8 to 12 millimeters. Now, mouth opening of greater than 30 millimeters is considered to be light trismus. If the mouth opening is between 15 to 30 millimeters, it is considered as moderate, and if it is less than 15 millimeters, it is considered to be severe trismus. A thorough knowledge of the anatomy of the muscles of mastication and the movements of the temporomandibular joint aids in understanding of this clinical symptom. Now let's get back to our anatomy and recollect what are the muscles which elevate the mandible. That is, what are the muscles that close the mandible. So basically, there are 3 pair of jaw closing muscles. These include masseter, temporalis, and the medial pterygoid. The powerful masseter and the temporalis muscle, by their size and point of insertion, exert a strong closing force. The medial pterygoid is also a thick, powerful muscle which is inserted onto the internal surface of the ramus of the mandible and down to the angle. Now, what about the muscle that opens the mandible? Lateral pterygoid is only muscle of mastication that assists in depressing the mandible, that is opening the jaw. It is also assisted by mylohyoid, anterior belly of digastric, geniohyoid, and infrahyoid muscles. The muscles of mastication can exert a combined force of 100 to 300 pounds, and those that open about 25 pounds. That is, one pair of muscle should act against three pair of strong muscles. So this relative weakness of opening musculature is a prime factor in the patient's inability to open the mouth when pathology limiting the mandibular motion exists. Several conditions may predispose an individual to develop trismus. Etiology of trismus can be divided into intra-articular causes and extra-articular causes. Intra-articular causes, that is, the factors which are present within the temporomandibular joint. So these include ankylosis, arthritis, and meniscus pathologies. Now coming to the extra-articular factors, that is, the factors which are present outside the joint. So these can be further divided as infection, which could be odontogenic or non-odontogenic in origin, trauma, dental treatment related, TMDs, that is temporomandibular joint disorders, tumors, drug related, radiotherapy and chemotherapy, congenital, and miscellaneous factors. Now let's look at each factor in detail. The hallmark of masticatory space infection is limited jaw opening. In case of infection, the pain and the limitation of opening are usually progressive. The infections causing trismus may be of an odontogenic or a non-odontogenic in nature. Odontogenic infections have 3 major origins like pulpal, periodontal, and pericoronal. The presence of an oral infection, particularly around an erupting mandibular third molar, is the most common cause. The non-odontogenic infections such as tonsillitis, tetanus, meningitis, Parotid abscess and brain abscess may also cause trismus. Trismus can be the primary presenting symptom in 50 to 75% of the tetanus cases. There's a marked increased tone in the central muscles with superimposed generalized spasm in tetanus. The spatula test is a simple bedside test to diagnose tetanus. The posterior pharyngeal wall is touched with the spatula in this test, and if it is positive, a reflex spasm of the masseter occurs instead of the normal gag reflex. Trauma. Fractures, particularly those of the mandible, may cause limited jaw opening. Depending upon the type of injury and the direction of the traumatic force, the mandible tend to fracture at different locations, so producing mandibular hypomobility, like in case of mandibular condylar fracture. And there's another relatively rare cause of trismus seen in general practice is trauma of zygomatic arch or ZMC. So these fractured segments, they overlap and interfere with the movement of the coronoid process. Now trismus related to dental procedure. Trismus is a well-recognized potential complication of inferior alveolar nerve block and is usually attributed to inaccurate positioning of the needle when giving the block. If you can remember the landmarks of IAN block and the path of needle during insertion, the needle should be placed in the pterygoid space, which is bound by internal oblique ridge of the mandible on the lateral side and pterygomandibular raphe on the medial side. Now, whenever the muscle is accidentally penetrated or the virus is penetrated, it leads to bleeding, and this bleeding is leads to hematoma formation, and this hematoma, it gets organized and finally leading into fibrosis in the muscle. So post-injection trismus is related to tearing of masticatory muscle by penetration of the needle during insertion to the muscle, and the most commonly involved muscle in case of IAN nerve block is medial pterygoid. So good injection technique by staying lateral to the pterygomandibular raphe during penetration will avoid the medial pterygoid muscle, and since this muscle lies medial to the raphe, we should always be onto the we should be lateral to pterygomandibular raphe. Temporomandibular joint disorders. The two common types of TMDs that may result in trismus are myofascial pain and disc displacement without reduction. The limited mouth opening is either voluntarily induced because of the pain or because of the true locking as a result of internal displacement of the disc. Tumours and the oral malignancies. Trismus is cited as a very common finding in parapharyngeal space tumors, and trismus is frequently seen in patients suffering from malignant tumors of head and neck. Thorough clinical and radiographic examination must be performed to rule out the neoplastic possibilities. Oral submucous fibrosis is a precancerous condition commonly seen in people from Indian subcontinent. This causes blanching of mucosa and can affect the speech by restricting the tongue and the soft palate movements. The exact etiology is unknown, but it is most commonly attributed to betel nut chewing. There is a classification of oral submucous fibrosis based on the interincisal distance, wherein group A is mouth opening greater than 35 millimeters. And group B include the mouth opening if it is between 30 and 35 millimeters. In group C if it is between 20 and 30 millimeters, and group D if it is less than 20 millimeters. Some drugs are capable of causing trismus as secondary effect, like succinylcholine, phenothiazine, tricyclinic antidepressants and metoclopramide are more common. Hence, it is very essential to take a proper medical and drug history in patients presenting to us with trismus. Trismus and Oncology. Radiotherapy is one of the major treatment modalities used for management of head and neck malignancies. It can be used as a primary therapy for many like early stage malignancies, or as an adjuvant therapy following surgical resection, or in conjunction with concurrent CT for later stage and unresectable head and neck malignancies. So trismus in oral oncology is mainly because of radiotherapy-induced fibrotic changes of the muscles of mastication, or in case of OSMF, and less often in pharyngeal infections and oral mucosal disorders. Now, when the muscle of mastication are within the field of radiation, fibrosis may result and lead to trismus, reducing the range of movement. The mouth opening after radiotherapy decreases on an average by 18 to 32% compared to the mouth opening prior to radiation therapy. So doses as low as 15 diarrhea resulted in functional impairment. There are certain syndromes associated with trismus. So these include trismus pseudocamptodactyly syndrome, hemifacial microsomia, and Gaucher's disease. There are a few miscellaneous causes wherein we can find trismus, like hysterical trismus. It refers to a muscular limitation that is a consequence of psychological trauma, and the presentations are varied and include paralysis, blindness, anesthesia, anorexia, and vomiting. There's another condition called as Myositis ossificans. It is a rare disease wherein we find heterotopic ossification in the muscle or the soft tissue following any trauma. Trismus can dramatically affect the quality of the life in a variety of ways, which include poor oral hygiene, the complication of condition associated with head and neck cancer treatments, there's reduced access for oral examination and dental procedure, patient complaints of dysphagia, aspiration and related complications, patients suffer with malnutrition, there is decreased access for medical procedures including intubation, inability to use dentures or oral and pharyngeal prosthesis, speech difference and airway compromise. Now, how do we manage or how do we treat the patient with trismus? Treatment of trismus varies depending on the etiological factors. Supportive measures and rehabilitation are the main line of treatment for trismus. How do we manage a patient with trismus following dental treatment? Some difficulty in opening the jaw on the day following dental treatment in which a PSA or IAN block was administered is frequently encountered. So whenever patient complains with mild pain and dysfunction, an appointment for examination should be arranged, and in the interim the practitioner should prescribe a heat therapy, that is placing of hot moist towels on the affected site for 15 to 20 minutes every hour. Analgesics. Aspirin is usually adequate and its anti-inflammatory properties are also beneficial. Patients should be advised to have soft diet and if required, prescribe muscle relaxant. So this manages the initial phase of muscle spasm. Now, when the acute phase is completed, the patient should be advised to initiate physiotherapy for opening and closing the jaws and to perform lateral exertions of the mandible for 5 minutes every 3 to 4 hours. Sugarless chewing gum is another means of providing lateral movement to the temporomandibular joint. If pain and dysfunction continue unabated beyond 48 hours, that is, there is no improvement, the possibility of infection should be considered and the antibiotics should be added to the treatment regimen and continued for 7 days. Trismus and Oncology. Exercises are frequently proposed to prevent or treat trismus, including the active range of motion exercises combined with passive range of motion exercises. So traditionally, mouth opening using finger-assisted exercises, mouth gags and tongue depressors were used. Now currently, there are several commercially available devices that keeps the mouth open in a graded manner. And these include the rubber plugs, wooden tongue blades, terabyte exercisers, and dynamic bite openers. Terabyte is a therapeutic patient-controlled mouth opening device which has got two mouthpieces that are inserted between the teeth of the upper and lower jaw. When the pressure is applied on the handles, the mouthpiece opens. So this indirectly is putting pressure on the jaw in the opposite direction. This is a Dynasplint Trismus System. It is a therapeutic mouth opening device and it incorporates a custom mouthpiece to accommodate the partially or fully edentulous jaws. The patient can use the device in a handheld manner or can just attach the counterbalance bars. So this provides a hands-free therapy. Now, this is found to be effective in reducing the cancer therapy-induced trismus. And the biomechanical modality of this is with a low load and prolonged duration stretch was attributed to the success in reducing contracture. This provides sustained tension on the affected joints to allow for a gradual increase in the range of motion. The proper placement of this device is a key for success. Threaded tapered screw. This appliance is made up of acrylic resin and it is one of the inexpensive and easily available device. So this appliance can be placed inside the mouth of the patient between the posterior teeth, and with gradual turns the maxilla and mandible teeth are spread apart. So this appliance provides force that can be controlled by the patient. The only disadvantage is that it is not used for edentulous patients. Pentoxifylline is a methylxanthin derivative and its applications in oncology is promising. Studies have shown that pentoxifylline administered to patients with radiotherapy-induced fibrosis has resulted in a significant increase in the mandibular range of motion. Pentoxifylline also influences cytokine-mediated inflammation. So, coming to surgical aspect of management of trismus. Now, although there are no guidelines available for the surgical treatment of trismus, it is usually used when conservative treatment modalities do not improve the outcome and apparent severity of trismus leading to functional disability. Surgery has been used in severe trismus in OSMF by complete release of fibrotic tissue with coronoidectomy and placement of interpositional grafts. So the grafts used have been divided into local flaps and distant flaps. Local flaps are the ones wherein the donor sites are present in the head and neck region and they're transposed to the oral cavity by pedicle attachments. The distant flaps include free flaps with AV anastomosis from donor sites in the arm and thigh. Local flaps can further be divided into intraoral and extraoral. Intraoral flaps like a tongue flap or palatal island flap can be used, and extraoral flaps like nasolabial flap or temporalis facial flap can be used. Now, the main disadvantage of using intraoral flap or the main limitation for using intraoral flap in OSMF is that usually whenever the patient presents to us with OSMF, the complete oral cavity might have been involved by the disease. So we need to make sure that whatever donor site we are choosing should be free of the disease. This is the main advantage of using an extraoral flap for reconstruction in cases like these. Buccal fat pad. Buccal fat pad as an interpositional graft is one of the most popular technique in the treatment of oral submucous fibrosis. The easy access of the buccal fat tissue in close proximity to surgical site, its volume and its non-involvement in a disease condition make it an ideal choice for the donor site. In addition, the relative less morbidity associated with the procedure and the simplicity of the technique of harvesting the fat tissue justified its popularity. Now, major hurdles included are the limited reach of flap for coverage of the anterior region of the oral cavity, the chances of damage of the parotid papilla and the duct during harvesting, and secondary infection in the postoperative phases. Coverage of the fat tissue with collagen membrane and split skin grafts have also been advocated so that this problem can be circumvented. Distant flaps. Now the free flaps serve the advantage of secondary donor areas unaffected by the local disease process, and there is no anatomical restriction in the oral region, and there is abundance of virtually all forms of tissue layer, whether it is a muscle, bone, etc. Now, the radial forearm flap and the anterior lateral thigh flap are the commonly used ones. The high expertise, high operating cost and potential failure of anastomosis are the prominent drawbacks of these distant flaps. Radial forearm flap. The technique of bilateral small free radial forearm flap has the merit of transferring a well-vascularized skin flap. Thus, the prevention of scar contracture and there is definitely a decrease in the recurrence of trismus. However, there are also few disadvantages with this technique. So we use two flaps here, that is 2 instances of microsurgery are required, and the procedure is time consuming and technically demanding. And also it involves 2 forearm donor site, thus we're sacrificing the bilateral radial arteries. Recently, the use of anterior lateral thigh flap has gained popularity for head and neck reconstruction. The popularity of this is because of the long vascular pedicle, large skin paddle and decreased operative time with the two-team approach. And finally, to summarize, trismus is not considered a disease or injury, but rather more the result and one of the concluding sequelae which follows after the active stages are healed. A systematic approach using a disciplined and organized thought process is more likely to yield an accurate diagnosis. For the clinician to diagnose trismus properly, he or she must be able to determine the cause from a variety of possibilities. The treatment objectives are to remove edema, soften and stretch the fibrous tissue, increase the range of joint motion, restore the circulatory efficiency, and increase the muscle strength and retain the muscular dexterity. With this, I would like to conclude my presentation. I hope you find this presentation useful. And if you have any queries, you can please leave the comment section below. And thank you so much.